Shankar, please come. Each faculty talk is 7 minutes.
Namaskar, good morning. It is indeed a pleasure to be here and salute all my parent organizations, ophthalmological associations, which has curated me and made me an ophthalmologist, and happy to present in the fourth midterm conference of the All India Ophthalmological Society and the 27th conference of the Punjab Ophthalmological Association. And that's me. I am presently the chairman of Academic Research Committee of the Tamil Nadu Ophthalmic Association. And today, the patient, the boss. Why I call the patient the boss is we need to understand every patient is important in our premises. We need to believe that. Mahatma Gandhiji had said in his own words that every customer is important in every business premises. We are doing, of course, health business. We need to understand that. We do service, but it's our business what we take over. And the patient is the boss, actually. Welcome to Amritsar, a lovely place, a land of holy shrine. And I'm visiting Amritsar for the first time, and when I was there day before yesterday night, it was simply magic over there. I felt the spiritual feel inside the shrine, and I did enjoy the external thing also, and of course Amritsar for its cuisine also. And medical care is not like before. Medical care has changed a huge way, and you can see like this picture over there, you can see you have a double-decker treatment care happening, and there are medical errors which still happening, fortunately or unfortunately, knowingly or unknowingly, but we need to try to reduce the amount of medical care. How are we going to do? Because every sunrise the care begins, and ophthalmology is our bread and butter, and the patient care, when we see the patient, is very, very important. I would like to say this is my only important slide. Of course, all other slides are very useful. From the security level to the medical director's level or the senior consultant's chamber, the language needs to be the same. If your security or a reception staff talks something, your optometrist talks something, your counseling talks something, ultimately when you say something to the patient, there comes the problem. So you need to be very, very cautious. If your patient is unhappy at your security level, they are going to be unhappy throughout there in another 1 hour in the hospital. So the language spoken is very, very important. The reception area, the most toughest area, and the first point of contact, you should teach your receptionist to welcome with a smile. A smile makes a huge difference. If somebody smiles at you in the conference when you're walking in the corridor, are we not happy? So that's the same thing the patient expects. And ask your reception staff not to chat. They do chat, they have their personal problems, they then chat not in front of the patient when they are there. Without the patient in their front, they can talk, chat, do whatever they want. Talking loudly, smiling loudly, laughing loudly when in a waiting hall doesn't sound good at all. You need to teach your reception staff not to do that. The patients may be the customers for the business of health, but they come with pain and they expect attention. When you go to a hospital, when you take your parents to an hospital, don't we expect the same thing? We expect that extra care, that extra sympathy, empathy, everything over there. So that extra attention needs to be given over there. Even the consultant should have a smile in face, not having all home-related problems, business-related problems, stress-related problems in the mind, and talking to the patient. Smile, I, hello makes a huge difference, and a prefix of Mr., Mrs., Miss, Master before the name, they feel so happy. It does make a huge difference. And whenever the patient in front asks you, even in your optometrist's cabin or even in your consultant's cabin, allow them to talk. Once a single point patient says, सर लाल हो गया, सर कल से लाल है, इतना गुजली है, मैं क्या करूं? You know, you've seen through the slit lamp, you know it's a red eye, you know maybe a viral conjunctivitis, maybe allergic conjunctivitis. You immediately say, ठीक है, ठीक हो जाएगा, दवाई लिख के दे देगा, ठीक हो जाएगा, चलो bye. Don't do that. Allow them to talk, give them some time. And let them talk, and after that discuss with them. Tell them, so this is viral conjunctivitis, or this is allergic, or probably this is vernal. It would never go for a long time. Please wait. It's going to be there for a while. The seasonal conjunctivitis has its own course. So discuss with them, explain them, make them aware of the disease so the patient feels much, much happy, and you will never lose that patient. I'm very, very confident of saying that. It's a very old slide. I've been using this for 15 years now. It's an old paradigm when I say I am the king, no more. Let the patient wait for me. The patient is a king. The patient is a boss in our premises. We understand certain patients are very cribby, certain patients are very tough to handle. But if you start correcting yourself certain levels, definitely they are happy. See this video and just see what's happening. And the optometrist is enjoying, everybody is enjoying, I am enjoying, except the patient. Audio to chalana, please. ठीक है, no problem, no, don't worry. The patient is sitting over there, the optometrist is chatting with a colleague of his optometrist, says, hi, did you have your lunch, everything. There goes the trial frame. You don't have an audio, so the optometrist gets a call. It happens in every hospital. If somebody says it doesn't happen in your hospital, I would not agree. That just a minute doesn't matter. The patient will get angry. Okay, chalo, I'll go to the next slide. See, this is really unfortunate. This is really unfortunate, and sometimes the same thing happens in your consultation chamber where the patient is anxious, the patient relative is anxious, the attendant is anxious. This doctor at least uses some place to sit over there. And they are expecting something to talk about the disease, about the problem, about the treatment. Not, of course, we have EMR in all our hospitals. EMR is important. Don't go sit in front of the EMR, start typing something, take a phone, talk. They are anxious. Okay, sir, you have cataract in both eyes, right eye more than left eye. You have to do surgery. You go meet the counseling department, okay? So this is not the way to say. See, it's counseling department have their own job to do. I don't deny that. But you need to talk, convince the patient at your level. I know every one of you does it. Most of the seniors do. Most of the juniors do. I do agree. Talk convincingly to the patient. Make them understand these are the possible lenses we can use, etc., etc., and go off. I'll finish off within half a minute, so sorry. Do not talk about various things while operating. There's the biggest problem in the operation theater. And whenever an instrument doesn't work, I've seen surgeons throwing it. I've seen surgeons thrashing it away. But still, you throw it or keep it or thrash it. That's your headache. Don't complain on your nursing staff over there and saying that, "Kya de diya tu? Ye kaam to nahi kar raha hai." If you do that, the patient, after a 6/6, beautiful vision, with a slight post-operative dryness, itching, will say, वो इंस्ट्रूमेंट ठीक काम नहीं कर रहा था, इसके लिए मुझे ये आ गया, बस. So don't talk in front of patients. Be calm as a surgeon, even while operating. Very, very important. Very old slide, once again, benchmark. We are doing an hospitality sector business, not just hospital. Remember that. That's what you can say, welcome back in your hospitality industry. Of course, you can always tell them, we are there to take care of you, your colleagues, your family. Please come back. We'll take care of you. And this is a patient-different quality according to the importance. You see, the least important in the whole list is state-of-the-art equipment. The immediate attention at the reception, 81%, care first, then paperwork, and knowledge of the personnel. Everything counts more rather than your equipment. So these things play a vital role. Of course, state-of-the-art technology is very, very important. Remember, one day you also will be a cataract patient. Do unto others as you would have them to do unto you. And do all this and make the patient a delighted patient. Be happy always. The surgeon is happy, the patient is happy. A big thank you to all you all. Thanks a lot.
Good morning, everyone. Just to add to Sir's point, like I also had a similar experience. Like my OT staff was not trained. I told her that lens open kar do. There is a blade. Open it with box नहीं खुल रहा था उससे. तो patient thought कि I have used blade in his eye.
resident to put last stitch and patient heard. Even after 10-15 years वो बोलते हैं कि मेरे को वही टांका दुखता है जो डॉक्टर ने नहीं लगाया वही दुखता है वो कि नहीं पता इधर है कि इधर है बट वही टांका दुखता है जो उसने डॉक्टर ने नहीं लगाया था
And
So it's really
one more incident, I was doing AGV and I use 20 that needle, 30 gauge needle. तो असिस्टेंट वाज डिस्कसिंग में मैम आप ये यूज़ कर रहे हो वो वाले डॉक्टर तो वो दूसरी नीडल यूज़ करते हैं तो आई टोल्ड हिम आई एम कंफर्टेबल यूजिंग दिस नीडल ठीक है दो दैट पेशेंट वाज वन ऑफ द CEO ऑफ अ मल्टीनेशनल IT कंपनी so next day he told me that ma'am you both were discussing different types of needle during the surgery why you use this needle he discussed me a lot and that time I was doing a job so he convey this message to my boss also ki they were discussing these things so talking in a OR is very tricky matlab even I will discuss. One tip was given to me: if you have a rent, just tell your assistant to lower the height with the hand movement, like इशारे से बता दो, but don't speak. So these are the lessons we never like study in textbooks. So that's why conferences are very important. So I'll be discussing. Coming to my topic, can I have my slides, please? I'm Dr. Prachi. So my topic is lessons I never found in textbooks. Okay, so being a mastering the art of tasker, like you have to attend conferences, OR, family, kids, SSTC, DSTCs. So the most important is how to deal with real world patients. Listen to your patient. I think Sir has covered most of the points. Answer all their queries. Discuss all treatment or investigations option available. Build a good rapport between them. Patient facing vision loss, anxious or non-compliant patient, poor financial condition or emotional and psychological challenges. Like I'm a glaucoma specialist, so I always ask patient before starting PG analogs whether will you be able to continue this drop lifetime or should I start you with just timolol or 50 rupees drop. And breaking the news of any disease, being a cataract only or being a glaucoma or any ARMD or diabetic retinopathy, it should be slowly and gradually. You should not directly break like you have a cataract because many patients still they are not like mentally prepared for the cataract surgery. Okay, emotional and psychological challenges are also very important and always under promise them and over deliver them. Don't promise कि cataract के बाद बिल्कुल 6/6 and 6 vision आ जाएगा because even with many multifocal trifocal IOLs patients are still 6/6 unhappy. So effective patient communication is very important. You should be like doctor should have ability to listen. Like sir has also told that clinical experience matters less these days. Your ability to listen matters more. So being a solo practitioner, I have learned all these things even to financial manage my clinic, whether to buy a place or rent a place, equipment dealing with AMC, CMC, staffing, mutual funds, SIPs, loans, or either bundling, GST billing, and even hospital registration. I never learned in textbooks. So, but still, I invested in a all equipments like OCT, visual fields, but those are pocket friendly OCTs, no financial interest. So invest in a good machine, those can boost your confidence and give good visual outcome to the patient. For a beginners, I would suggest always go for a new machine, don't go for a second hand machine, because you won't have much support later on. Registration and empanelment, how to register your hospital with government, when to register, when to empanelment, should we do on our own or hire some agents? Fire safety, BMWs, DPCCs. Okay, marketing, traditional versus social marketing, these both are very important. Your social presence is very important. Whenever we meet a new person, we try to search him on Facebook, na, ki how he is. So it's very important. Whether you are doing your any of your practice, just and attending any conference, just put it on your social media. Reference to and from is also very important, from optometrist, other ophthalmologist colleague, general physicians. Time management, like hospital timings, OPD, OT management, conference time, family versus fellowship, and personal versus professional life. Like I manage my OPD, OT with my two kids, and thereafter I may have some me time. So these are my some few of my achievements, where I have received few awards. So, self care is equally important. Your surgical hands also need sleep, hydration, and calmness. Otherwise, you may develop a musculoskeletal disorders, neck, wrist, back. So, find time for yourself. So, enjoy the process. It is a journey. The work is never quite done. It is always a work in progress. Give maximum time to your practice, but get professional indemnity done. So, provide holistic care with empathy and relevance to provide wow factor to all patients. Thank you.
Thanks, Praj. Any question if any would like to ask? Okay. So our next speaker, Yogita Chaurasia, counseling for a guarded visual prognosis.
Good morning, everyone. Thank you for the opportunity. Yeah, thank you. So, we have counseled a patient for a guarded prognosis now and then. So, I'll just make sure that we know the salient points. A guarded visual prognosis means that true extent of disease potential, visual potential after an intervention or during the course of disease is uncertain. Can be due to primary pathology, due to existing pathology, or due to can be some cases there can be a nil visual prognosis also. There are multiple causes of visual prognosis guarded due to a primary pathology. Similarly, there are many cases where there are some co-pathologies which can complicate the primary case. And there are some scenarios where there is no visual prognosis, nil visual prognosis, or no visual gain after a process, or even without a process. So, what are the so there's a clinical evidence of there's a study conducted to see the causes of guarded visual prognosis during a cataract surgery. ARMD, glaucoma, corneal or vitreous opacity, diabetic retinopathy. These are the main factors noted there. So what is the need of counseling? So it can help patient understand the condition and accept their prognosis. And it can also help patient make decisions about treatment such as surgery and improve compliance with their treatment. Counseling can help them motivate for alternate options also for rehabilitation when needed. When to provide counseling? Before a surgical procedure, before any other procedure, or even if we are not doing any intervention, like in the cases of RP and all. So whenever there is a guarded prognosis, we have to really explain it. When to provide counseling for a GVP can be pre-operative, pre-procedure, post-procedure also we can tell them about the outcome, and long-term support is also needed. Who can provide counseling? The treating doctor, junior assistant doctor. Professional counselor can be hired, or you can make a separate counseling department in your hospital. And any staff can be trained for the counseling also. The types of counseling, there can be individual counseling, this is to talk one-to-one with the patient to explain about the disease and treatment plan. And there can be group counseling, which can be client centered, where a patient and his family are explained in a group. And there can be a group having a common ailment, which can be addressed at a community level. There are two core components of effective counseling. First is providing the information, and second is taking an informed consent. Providing the information, that is the most crucial part, because the patient understands everything in this. So you have to mention the diagnosis, the intervention they need, the need for intervention, the risks for undergoing or delaying the intervention, and the possible benefit and the long term prognosis too. So it should provide you the patient with a very clear diagnosis, explain the condition in understandable terms, and avoid complex medical jargon. Detail all the available intervention, including surgery, medical management, and observation too. The honest discussion of risk assessment should be done, and you should set realistic prognosis in front of the patient. The second and the most important component is taking an informed consent. But without priorly giving information, we can't rely on this alone. So it extends beyond signature collection. It represents a collaborative dialogue, ensuring patients truly understand their situation and treatment choices. So this is taken from an AIOS guided. There's a mini book of consent provided by AIOS. So that is taken from that. What are the key components of an informed consent? First of all, language should be, if the patient is a Hindi speaking or a Marathi speaking patient, then you have to do it in their language. Patient details has to be proper. Diagnosis has to be mentioned. I has to be mentioned. Procedure required and its need or indications, risk and benefits, reasons for the guarded visual prognosis, and declaration by the patient, declaration by the doctor. So these are the declaration by the patient and the doctor. The patient basically says, okay, I understand everything, and the doctor says, I have explained everything. So ATCOM is very important in counseling. Attitude is, the patient's attitude towards counseling can be affected by a number of factors, including their understanding of the condition, their faith in treating doctor and the treatment plan, and the availability of a proper time and setting, which is equally important. Ethics. The counselor should use empathy, respect, and support, and pay attention to the recipient's emotions. Communication is very important. The counselor should use simple, understandable language, as I said. They should also allow the recipient to ask questions and express their emotions too. So choose a comfortable and private location. Provide the counseling in person when it's convenient for the recipient and without any interruption. That is also important. Allow the recipient to be accompanied by a support person or a family. Prepare for questions, give explanation, allows other to speak, and explore solution with those involved. So there are certain barriers. First is the language barrier, you should overcome it. And then second is educational differences. The patient, you should look at the how educated or how and explain the complexity at their level. And culture sensitive, there are certain cultural beliefs also about the illness and treatment. You should respectfully give your opinion about that. So active listening, emotional validation, and an honest communication builds the patient trust. Setting realistic expectations prevent disappointment and builds trust. So discuss best case, worst case scenarios, most likely scenarios, while emphasizing that individual outcomes may vary significantly based on the multiple factors. Immediately follow up, schedule timely appointments to address emerging consent, and so it should not be a one time thing every time. Sometimes we can just provide the counseling, tell them to come back and again ask question and then take the consent. That also can be done. And resource provision, if they say what to do, then you have to have a resource of providing them further, guiding them further how to proceed if you are not providing that facility on your at your clinic. And ongoing additional support should also be. So it is said in the studies that it improves compliance by 78%, reduce anxiety of the patient by 65%, and increases the patient's satisfaction by 82%. So effective counseling for guarded visual prognosis is essential for patient care and should be emphasized in routine clinical practice. It builds better doctor-patient relationships, improve treatment compliance, and help patients adapt to visual challenges with greater resilience. Thank you.
Regarding this counseling and consent, this is looking very simple, but one has to be very careful.
Yeah.
And now the alternative of video counseling is also
Yeah.
there sometimes.
Yeah.
And one thing I'd like to mention, because last week in our local IMA, we called one legal advisor to discussion upon this counseling and this consent. So one point I got from that meeting, maybe you may be aware of that, from 12 to 18 years, consent of child as well as parent both required.
Okay.
Because previously we are under the impression that if adult, then patient can give the consent, and if छोटा बच्चा है तो उसको फिर उसका गाइड पेरेंट ही देगा, लेकिन 12 to 18 signatures of both child as well as parent both required. Yeah.
Yeah.
Yes. And if
For
you
video,
want to
for
use,
even for doing case reports and all, we are not required to
Yes,
take
exactly.
and produce that counseling, that consent paper also with the case reports.
Yes,
Yeah.
exactly.
And in such a situation, you need to also explain to the patient that your identity will not be
Yeah.
revealed. Okay. Same line wise, because we have done the translation in various languages and put
But
it.
main point
But
is
this is good. Like,
make him understand what you are saying, not just signature. Anyway,
Thank you.
so our next speaker, uh, Rahul Deshpande. Is he not here? Sir, next आपका है सर, AIOS सुरक्षा सर. AIOS सुरक्षा.
so this is a comprehensive security initiative that we have initiated in AIOS for the last 2 years, titled AIOS Suraksha. So for your secure career, you need to have professional security. You need to have a personal indemnity insurance, a hospital indemnity insurance if you are running an eye care center. And then nowadays you need to protect yourself from social media intimidation as well as legal protection. This is not just it, we give too much importance to only our profession. We also need to take care of ourselves through personal health insurance, term life insurance, and then motor vehicle insurance. Like almost all of us, we do have our own motor car, so it reduces a lot of stress on our side. So a comprehensive this thing. So what is professional indemnity? Is an insurance plan to financially safeguard medical practitioners against legal costs and claims for compensation by the patients in case of a legal row. The doctor's expertise is protecting the health of their patients, and medical insurance experts advises the doctors how to protect their business interests. What is the necessity for this? There is a staggering increase of 5.2 million medical negligence cases annually in India itself, and this constitutes about 110% increase, a whopping 400% surge in legal battles, and it is so critical to safeguard the rights of the doctors. Before we move further, we also need to understand this term, the vicarious responsibility of a hospital. Means a party is held responsible not for its own negligence but for the negligence of another. In context of medical malpractice actions, hospitals can be held directly liable for their own negligence and can also be held vicariously liable for negligent actions of an employee. So the hospital is legally liable for any malpractice committed by a physician, nurse, or any healthcare provider who are employed in the hospital or visiting. The scope of professional indemnity insurance is to provide cover for the extent of financial damage, and it also covers the cost of defending oneself in the court of law, that is the cost of decree. So indemnity insurance policies should be taken for doctors and hospital staff separately and should be renewed every year to meet the claims of Consumer Protection Act. What we need to understand is the copay or the riders. The calculation of premium depends on any one accident, limit, can be 25, 33, 50 or 100 selected, and any OY, any 1 year limit. What is AOA? Like one insurance agent may approach you and say, I'm giving you 1 crore protection for 16,000 rupees. Another may come and say, I give you that for 8,000 rupees. What is it? This is it. You have to read between the lines. AOA 33.33% means even if you take a cover for 1 crore, for one accident, you will be liable, you will be compensated only for 33 lakhs. That is the thing why the premium differs. The most important clause to be understood is the act has to be committed during the period of insurance commencing from the retroactive date and continued thereafter without break. Take home message for professional indemnity: there is no grace period. Unlike other policies, you get a 1 month grace period. The policy should be mandatorily renewed before the due date. If even there is a 1 day break, if something happens a little before that due date, you won't be covered because you are having a break in your policy. So this is most important. So based on this, we selected a insurance broker that cover you for providing insurance suraksha, because this is the only IRDI accredited broker, exclusively caters for the doctors with all these facilities. Because of paucity of time, I won't be able to explain each and every policy. So we are introducing a customized professional indemnity policies exclusively for AIOS members. It has various advantages compared to you taking it individually, and most important thing is even oculoplasty, ocular oncology, and cosmetic procedures done by ophthalmologists are included in this, whereas the premium is almost double if you take it on your own. Then these are all the 18 important advantages if you are taking, we as a group Alamkit AIOS Suraksha, and you just see the premium. Like I was having a 50 lakh policy for, I was paying about 12,000 rupees. Now with AIOS Suraksha, I ported my policy with AIOS Suraksha, and you end up paying only 3,245. This is the power of group, and over 900 people, AIOS members, have already taken. Hospital professional indemnity insurance also, like as I said, we need to have a hospital cover, because if you're transporting a patient inside, suppose the patient falls down from the trolley, who is responsible? It's not you. Your hospital will be held liable. So, and cyber security, social media, and personal accident, we have floated negotiated a policy like called Cover Prime with AIOS, under AIOS Suraksha. Then on your personal health, you can go for your health insurance. You can protect yourself first by taking a term life insurance, although we do have a family benefit scheme of AIOS, but it covers only 49 years. But this is an important message for all between 49 and 60. If you have to take nowadays, when I was a PG, like I took an endowment policy. Endowment policies are a no now, because you are paying so much for your life cover in that premium. So it's better to go for one term life insurance, insure yourself securely by paying 15 to 20,000, cover yourself for 2 or 3 crores. Your lifetime insurance is done. Your eventually is taken. Rest of the savings you invest in high return policies like mutual funds or these things, and you can earn much better than taking LIC covers, LIC endowment policies. And last but not the least, up to 4 motor vehicles cover you provides under a single policy with added benefits. All these brochures are uploaded in the website. What you need to do is, you just have to approach our website and do it. AIOS Suraksha, all insurance policies are a direct contract between you and the insurance company, with the broker helping you, and AIOS is only a facilitator. What you need to do is go to our website. There is a AIOS Suraksha tab, click on cover now, fill up all the details. Send the response. Why this is important is because your data is stored only in AIOS server, and we have given only the API credentials to cover you. They will be seeing from our website and doing. So what advantage we are getting if you are taking is, you are getting a professional 10 lakh free professional indemnity cover. All AIOS members, if you go to this tab, click on cover now. Even if you don't take any policy, just fill up your details. Cover you will stay in touch until the time you take time to decide yourself what policies you want to take or this thing. They are directly offering you a complimentary 10 lakh AIOS Suraksha for AIOS members. So a complimentary professional indemnity cover. Request all AIOS members, like as of now, as I said on the professional front, about this is the statistics, over 900 members have been benefited through our website by insuring themselves professionally as also on the personal front. Thank you very much.
Sir, this is separate AIOS Suraksha or AIOS website incorporated in
AIOS
that?
website only. Like when I became the treasurer, I gave importance to this. I said just doing conferences or CMEs is not the only thing. You need to think of our members, how they should be protected professionally
So it is
as well as.
separate
No,
website.
it is the same website.
Same
As
website,
I
incorporate.
showed you, yeah, it is the same website. There is a AIOS Suraksha tab in that. There is a button cover now. You go to click cover
So
now.
which
you get,
company is taking care of this?
Cover You.
Cover
Cover You is an insurance broker, IRDI recognized insurance broker. They are covering almost 80 professional organizations all over the country. They cater exclusively for doctors. Most of the IMA branches, Foxy, orthopedics associations, and also AIOS also we negotiated with them. We got good terms and conditions, and
really good,
we are,
really
we
good.
are promoting this for our security of our members.
And if one wants to exit from FBS, one of my friend asking. So
There is an exit clause even in AIOS FBS. If you put up, if you have completed 20 years, you can exit, or there is an early exit option also every year. This thing, FBS, like you do have. I would like to emphasize why. I also endorse FBS. Like I will not exit AIOS FBS only for one kind of thing, like the difference between a term life insurance that you take, for say for example from Cover You, you may be having a better premium also. Like I was instrumental in floating FBS AIOS also way back in 2004 along with Dr. Sri Ramurthy and Dr. Vellabhupti Sambashiva Rao. So I had prepared the PPTs in those days for FBS. The thing is, they were comparing the premium with endowment policies. That was not true. We should promote only for the
that is not the
term
reason
life
of
insurance. Yeah.
exit.
So the premium may be like you are getting 25 lakh cover, but your premium varies between 600 rupees to 20,000 rupees. Also, we paid during the COVID time. That is this thing. The important thing is camaraderie. Like we are living, you are supporting your own member, paying 600 rupees for a demise of your member is something. Second thing is immediate reimbursement. Like you may be financially sound, your family may be
These are some
financial
points
sound.
well taken.
Yeah, so you get it immediately. Within processing time is just 2 weeks. Like by the time you are into other finances, your family struggles with trying to settle the other finances. Like immediately AIOS Suraksha, this FBS gives you the claim. So that advantage is there. So nowadays for the practitioners, for all members, all of us, like our days are gone taking endowment policies. Take a term life insurance, secure yourself in one place, then you opt for various saving schemes for your welfare. Thank you.
ठीक sir. Thanks sir. Our next speaker, Shri Divya. And topic, placebo therapy in eyes, is it getting rampant?
Good morning, everyone. My topic is placebo therapy in eyes. Is it getting rampant? So, basically, placebo is a substance or treatment that is designed to have no therapeutic value. We have conducted a very small questionnaire type study with about 50 patients who had symptoms like uneasiness, pricking, and watering. There was no significant abnormality on slit lamp examination, but these patients are very adamant that they want to use eye drops. So out of the 50 patients, for 25 of them we have given drops, and for 25 of them we have just given counseling that you don't need any drops. Of which 18 patients of the ones in which we have given drops, they are very happy once they have come for follow-up. and in which again 7 of them, they want better drops. They're not satisfied with these. And in the patients whom we have given counseling, few of them, they have never returned for follow-up, few are convinced, and 15 of them, they still want drops. So what are the different reasons why these patients are so adamant on these? Sometimes they misinterpret their common symptoms as something serious. They have this desire for quick fixes, that there'll be immediate relief for their discomfort or redness. And some patient, they have as consumer mentality. There is lack of trust in healthcare professionals or the recommended treatment. They have some illness experiences and beliefs. And most importantly, in today's world, like they have the influence of information. The internet has made it easier for patients to become internet informed, sometimes leading to self-diagnosis and demands for specific drops. So how is this placebo therapies related to eye-related studies? They are used already in clinical trials, dry eye diseases, glaucoma therapy, and also in certain vision therapies like convergence insufficiencies. When we come to dry eye disease, here the placebo effect is a major consideration, where the control treatment known as vehicle is not a true inert substance. The act of adding liquid to the eye provides temporary lubrication that can improve symptoms. Studies on dry eye disease reveal significant improvements in symptoms and certain signs in patients receiving a placebo or a vehicle. There can be a positive placebo response. There is a study called DREAM study in which participants on placebo showed significant improvement in subjective symptoms. Whereas it can also have larger effect for more severe symptoms. In the same study, it was shown with a phenomenon called as regression to the mean. But there is no long-term benefit. There was a meta-analysis in 2022 saying that placebos did not show a long-term beneficial effect on key dry eye disease symptoms and signs. When we come to placebo effects in glaucoma, it was effective in lowering IOP compared to baseline with a greater effect than no treatment at all. But this could potentially limit the ability to evaluate the efficacy of a new medicine. The magnitude of the placebo effect in glaucoma trials has been linked to factors such as larger sample sizes and add-on study designs. So why does basically this placebo effect occurs in eye therapy? One is because of the patient expectations. They believe that the treatment will work, can trigger the brain to release substances like endogenous opioids and dopamine, which can modulate symptoms like pain and comfort. Sometimes it is due to therapeutic contact, that is supportive interaction with the physician can create a positive expectation of recovery even from an inert treatment. And physiological effects of the vehicles like DED trials where they are not truly inert, and the moisturizing effect of the saline can provide temporary relief. And regression to the mean, where natural fluctuations in is their condition mean their symptoms would likely have improved anyway without an active treatment. So there are certain advantages like scientific reliability and safe for patients in research because of placebo. And disadvantages are mainly their ethical concerns in direct treatment, variability, their ineffectiveness for eye conditions, withholding effective treatment, and limited generalizability. So why is it problematic? It is basically because of the ethical concerns, because sometimes deceiving the patients by giving them inactive substance while implying it to be an active treatment is unethical. It damages the trust, that is the lack of transparency can erode the patient's trust in their doctor and the healthcare system, potentially leading to a harmful long-term relationship. There is something called risk of nocebo effect. Instead of improving well-being, placebos can sometimes cause negative side effects such as nausea or drowsiness. Then it can be a lack of benefit for conditions like dry eyes. It can improve symptoms, making it an ineffective strategy for genuine patient care. So how should we properly use placebos in healthcare? If we are using it in the clinical trials, it should be an informed consent. Patient should be informed that they may receive an inactive substance as a part of study, ensuring ethical treatment. And the primary goal of clinical practice is to provide beneficial and effective treatments, not to rely on deception. So finally, what I would like to say is patient satisfaction should be achieved through transparent communication, accurate diagnosis, and effective treatments, not through the unethical or ethical use of placebo eye drops. Thank you.
Your observation that in glaucoma cases there is an IOP drop with placebo is interesting. Like the way, yeah. So
Yes, yes,
actually,
yes.
yeah. Actually, no, no, no. What I am trying to say is like the very diagnosis of glaucoma generates so much anxiety for the patient, and the very fact that they are using some eye drop gives them so much relief, maybe contributing, like in the management of glaucoma for intraocular pressure reduction. Nowadays, the uh, study that was initiated by Dr. Tanush Dada at
Yes, yes.
AIMS about mindful meditation is really working. It is almost about 20% IOP drop is seen by 365 breathing. So these are the contributory factors, because once you tell the patient you are probably glaucoma also, mind you, patient will never sleep peacefully for the rest of his life. So that's a point well taken, and this is an interesting finding. I should say that the using even a placebo drop is contributing to some intraocular pressure fall. So it basically reduces the stress for the patient, I feel. Good
Okay, sir.
presentation.
Next speaker, Rutayani Dash.
Yeah.
Edipism, when psychosis reaches the eye. तो पहली बार नाम सुना।
So, good morning, everyone. This is just a case to just for public awareness. So, I have no conflict of interest and no financial interest. So, it is a rare but serious ophthalmologic and psychiatric emergency that usually occur in patients with severe schizophrenia and is life-threatening. The management usually is multidisciplinary, using ophthalmologists, psychiatrists, and neurologists in order to detect any associative lesion. Although it's rare, this phenomenon is still important to be recognized because of its visual and vital prognosis. So our case, what we have dealing with recently in the casualty, one 26-year-old male came to casualty with accompanying his father and friend with self-mutilated or enucleated his right eyeball completely. The eyeball was put in the plastic container with request to put it back, and he was suffering for multiple episodes of auditory and visual hallucination and was taken to local quack and tantric for the treatment family. But because of this command hallucination and visual things, see, he got irritated and finally enucleated his eye. When do ocular examination, obviously there is some excoriation, swelling and excoriation of the skin tag, and eyelash is matted, but cornea, the whole eyeball is nucleated, and conjunctiva there is tear. Left eye is very fine, and with visual acuity 6/6. So in fundoscopy, all this is the enucleated, and other eye is fine. So what treatment we have done? We have done the mild excoriation thing, and some laceration is there. So we have done lead suturing of the both eyes with removal of the remaining irregular tissue and skin tag. Dressing was done. Patient was treated with injectable of course antibiotic and referred to the psychiatrics department for further evaluation. We have done only NCCT of the brain to rule orbit to rule out an external injury and the presence of any foreign body. And after 2 to 3 days, patient was again operated in minor OT where the stitches of underlying conjunctiva tissue and trimming of the dead cell, and finally conformer and placed in the shape and contour of the right eye. So this is the final picture of the patients after putting the prosthesis. The psychiatric consultation, he was diagnosed a case of paranoid schizophrenia. He was on tab respiration, trihexyphenidyl clonazepam is being followed till death in the psychiatric department. In month later, the injury was healed and excellent tissue recovery, and prosthesis was then finally implanted in the right eye. This is the prosthetic eye. So as we discuss Oedipism, as we all know the things what Oedipism happened, what is the history behind it. So most of the Oedipism cases in the literature and association with psychosis, bipolar disorder, OCD, a schizoaffective disorder, and substance abuse. In our case, we find this hallucination thing and paranoid schizophrenia, grandiose, what we has getting commanding hallucination and do these things. In Indian literature, only 5 cases could be found, among which 2 cases had an association with schizophrenia, one with acute transient psychotic disorder and with depression, and one with bipolar with erotomanic delusion. This case, one bipolar and erotomanic delusion, is found recently in and this study is published in this case is published in IGO case report in AIMS, conducted in AIMS now 2024 only in August. And cases associated with bipolar and schizophrenia involved made patient experience religious or command hallucination, what commanding to remove his eye. This biochemical theory proposed self-renunciation could be associated with dysfunction of serotonergic and dopaminergic and opioid system. Mostly there is serotonergic high upper activity, and there is dopaminergic negative feedback is there. So there will be this thing is happening. So neurological evaluation should be done to rule out complication like intracranial hemorrhage, chiasmal injury, infections. Along with schizophrenic patient, they have done so many things. So you have to rule out all the neurological evaluation along with NCCT brain, and if required, there is MRI also. More research is required to understand the prevalence, underlying etiology, motivation, and its social impact. So to conclude, this case highlights the need for early identification, structured assessment, multidisciplinary approach to treatment and rehabilitation. Rural people should be made aware of ill practice and these tantric things, and to prevailing the far out place by local quacks, and myths and facts about eye transplantation and corneal transplantation should be addressed. So these are my references. Thank you.
Very unusual presentation, guys. And don't mind my ignorance. I just wanted to know the meaning of ODPism. Like even Dr. Ravi was saying, like this is the term we, as ophthalmologists, we are listening for the first time.
Oedipusm,
What
that
does it
is
signify?
actually there is a history behind this. One this thing is one king is there when the son. हाँ हाँ वो उसका हाँ जेसिका उसका वाइफ के नाम थे, उनका बेटा था वो इडिपस था, जो उसका लव रिलेशनशिप उसका मदर के साथ आ गया था. तो व्हेन ही फाउंड आउट टू रिग्रेट हिज सिंस, ही फोल्ड मतलब ब्लाइंड फोल्ड हिज आई, and again just his mother committed suicide. So this is the Oedipus, and we found in our MBBS days we read this Oedipus Electra complex. This thing in 2 to 3 years, if the things is fixed and there is love affair, her son to his mother and father to his daughter, and if this stage is not going beyond, and there's some trauma, some depression, psychological thing is happening, the stage is static is there. So this thing happened to Oedipus, who has done this sin to his mother. Then he not remove his eye actually, but he has blindfold his eye. So after that, this thing, Oedipism complex is there.
Good, very interesting to know.
Yeah, this is the self-mutilation cases.
Yeah.
Is it possible to remove own eyes?
Yeah, every
How he must have renucleated.
Recently, AIIMS people have done these cases. Actually, I have go through the article, this IGO case report in 2025, August only. They have found this in psychiatry department has published this article along with RP Institute. They have come across this case, and this case was a case of substance, and this patient has erotomania with some actress, and he can't see that actress with anyone else, anyone movies, and he found that he has constant thought that this actress with in being harmed by any other one, and I can't protect her. Yeah, so he self-mutilated his eye. This is a erotomania case.
The process of self-mutation is
It's a finger also.
with finger. It's not possible to cut optic nerve.
No, this case is not with fingers, but I found that article with
Blade, I don't think what kind of is accessible.
And these people not full.
थोड़ा सा भी करने
Don't
के बाद
yeah,
इतना
they don't
दर्द
feel
होगा.
pain. Don't feel pain. Any suturing also, we don't put any local anesthesia. Yeah. We
Severe of traumas, patients do not have any pain.
in whole cases we have don't put any
Kind of
anesthesia.
chemical khichdi is there that
Yeah. Yes, sir. Thank you.
So,
Thank you.
is Dr. Saloni here? Yeah, please come. For your last talk, don't just see it, ace it. The ideal way to win gold.
Good morning, everyone. They say the first talks are very special. So it's the first faculty talk I'm giving of my life. I'm extremely honored to be present
God
here
bless you.
and seeking all your blessings. So I'll be talking on don't just see it, ace it, the ideal way to win the gold. It was actually a postgraduate centered talk. So I hope someone takes some notes from it. Let's start with the story time. A girl got admitted into her medical college. She's very happy. We all were. She cracked her post-graduation exam, got into the department of ophthalmology. She was happy. We all were. But Many months later, she's confused. But why? Because everything is going on her mind. I'm forgetting everything I'm studying, how to make notes, how to manage the OPDs and the clinical skills, how to manage duties and study at the same time. Did you feel like it was your story? It was mine too. But I swam from the books and all this confusion and found a way out. And so I'm here to tell you all is well. I can help you the way I try to help myself. So what are the tips that I can give to the postgraduates who are just joining? The number one tip is avoid spoon feeding. MBBS and PG are very different from each other. Our focus changes from 19 subjects to just one subject. In the MBBS, we are trained by all these apps how to, like, they're spoon feeding us and we crack a postgraduate exam. And as soon as a new PG joins in our department, they ask, ma'am, kaun se app se padhe? Kahan se padhe, ma'am? So these apps are no for your postgraduate, I would say. Rather, focus on active learning. Train your brain every day. So the second tip I could give you is that OPD is the foundation block of your postgraduate exam. This is an OPD room. This was mine too, filled with patients. So it is where my learning started. The OPD duties are always underestimated. They are considered as a burden. Your patient is your topic that you want to study. His complaints are the symptoms that you have to write in your exam. What you see on a torchlight is what are the signs you have to write in your exam. So pay a deep attention to everything. So what to do in an OPD? Take a history, examine, show the findings to your consultant or your senior. It is like a mini case presentation that happens on the spot. See what other investigations are being sent by them, or what corrections are being done to your findings by them, what treatments are they giving, and click. I used to click pics of everything in my first year. So yeah, your topic is ready. So these are the pics that I still have kept with me of a patient who came to the OPD. I showed it to my senior. She told it's a case of papillitis, admit the patient. She told how to give IV Pred, 1 gram, 5% dextrose. We give it for 3 days. I was a newbie by then. And then at the discharge, she made me write all that, how to give tablet Omnacortil. I did not understand. Then she wrote this for me, what is the ONTT trial, how we give it. So how do I keep all these images together at one place, organized, is the Microsoft OneNote app. It is free of cost app. Anyone can use it. So this is the video recording of my mobile phone. This is the OneNote app. I have made all the folders, and in every folder, these are all the photos that I have organized so that they're readily available as soon as I need it, if I need it. So this was the papillitis patient. This was way back when I joined the ONTT trial. And then there's a case of like corneal ulcer, like what she wrote, what she gave as a treatment. And this was way back in 2022. It was just 1 month after me joining the post-graduation. So the PGs always ask me, ma'am, notes kaise banaye? Notes kahan pe banaye? So the number one option is you have copies, the old age books. The number two is the iPads. Everyone is trying to buy. So what happens with notebooks? They're cluttered. It's very difficult to edit. I would write, I would cut, I would put whitener, I would paste papers. It gets very difficult. I cannot put patient images. I need to print those, cut those, paste those. And I wrote a book copy, I lost it. 1 year of hard work, I lost it. And the second is iPad, costly, around 1 lakh, time consuming. The third, which I figured a way out for myself, was a laptop, because I bought it for like 30 to 40,000. Easy to edit, moderate cost, saves my time, compact, easy to carry, organized, backed up, and you can add pictures too. So writing a note is like writing a theory answer for yourself. I start with introduction, demographics, pathology, classification, clinical features, investigation, management, followed by I end it with the recent advances. This is the sequence I have followed throughout my notes. This is the sequence I followed in my theory answers. And trust me, my theory marks were much better than my practical marks. Maybe I got saved because of this. So what are the various note-taking apps? We have Evernote, Google Keep, Notion. They are paid apps. I didn't want to spend. So I used the old age Microsoft Word. So how did I use Microsoft Word to make notes? I write the topic. I make a table. This was the most helpful thing for me. I wrote what are the previously asked university questions on one side, so that when I'm opening it again, I know what I need to focus when I'm revising at the last moment. And on the right side, I wrote what are the resources that I used to make the notes. As you can see, I wrote this notes from Daily Journal of Ophthalmology and Indian Journal of Ophthalmology. I put a link of that article so that I can go back to it whenever I want to. I wrote the introduction, the classifications. Every journal has tables, pictures, flowcharts. Add those. It will be convenient in your exam. And then from the American Academy of Ophthalmology, I would annotate the pictures and I would keep it in my notes, so that along with the ophthalmology, I'm even aware about the radiology findings at the same time. So this is a video of how I organize all my notes in folder wise. The 13th is the neuro ophthal folder. I have all from anatomy to optic atrophy to optic neuritis. I have made all the notes. So this is the optic neuritis topic. As you can see, the heading followed by the questions and then the classification, the typical atypical optic neuritis. Shall I continue? The signs, symptoms, and yeah. So the next is journals. Someone told me read journals. तो समझ नहीं आता था कैसे पढ़ें उसमें से. But I could say after 3 years, make journals your best friends. It has everything at one place from A to Z. It is concise, full of images, simplifies things for you, and what you're doing is actively reading, actively training your brain. So various journals that are available to us are IJO, the Daily Journal of Ophthalmology. The fifth point that I can say is don't say alvida to your books. They should always be there. After you have read most of your things from your journal, the reading book just halves your time. And if you're someone who feels sleepy by reading books, go through journal followed by book. So I have made a folder for all my books which I've kept, and the number 1 folder is the must books, जो बार बार चाहिए मुझे. So over here is American Academy of Ophthalmology, the Khurana series, the postgraduate volume 1, Zia Chaudhary, the Kansky, that I need every day. You don't need to go into the folders and I want to find the book और मिल नहीं रही तो नहीं पढ़ेंगे, like that. And the number 6 is the videos. Supplement your knowledge, fill the lacunae. We have various video options available by the AIOS, the iFocus, the IZOG, the DOS. Again, your regional, this society would have their own courses. And there are webinars which are focusing only on pages. The PG Pinnacles and the PG program with the difference have literally made a difference in my life, in my coaching in this last 3 years. And then take the UG classes as much as you can. My juniors are here. Whenever I tell them take classes, they run away. हम नहीं लेंगे, हमें नहीं आता, कैसे पढ़ाएंगे? But I used to be like, ले लेते हैं, देख लेते हैं क्या होगा. So take UG classes. This is the batch I've taught for like 6 months. And then these were the messages you get, and it just makes your heart full at the end of the day that you have made some difference into their lives. And then your co-PGs, they are the best reflection of your knowledge. Engage in healthy discussions. That a patient came to me, I did this, what could you have done differently? You teach, you learn. She's my colleague, and maybe how much I've taught her, I've learned more from that. And then you chill also with them. And number 9, the seniors, they are your helping hand. Nowadays, the new generations are like, we don't want seniors, we can do everything on our own. But seniors are always your helping hands. They'll always save you when you're drowning. So these are my seniors who have helped me, and I'm always there for my juniors as well. And number 10th and the last, consistency is the key. At the end of 3 years, just keep on making notes, and at the end of 3 years, you'll have everything compiled up to study. It will be handwritten by you, full of pics, full of concept, and easy to revise. So the sad girl you saw earlier is now happy and ready for her exams. So to summarize, avoid spoon feeding. OPDs are your foundation. So be happy in your OPD duties. Keep patient data, pics. Note making is an art with journals and books, and consistency is the key. So a journey from Punjab to Tripura had been more than 2,700 kilometers, but it has been a very fruitful one and a very, I've enjoyed the process, and thanking the Almighty and all my medical colleges. Thank you.
Excellent
But
presentation,
main
Thank you so
Sadhani.
thing
much,
I
sir.
would like to mention about this is decluttering.
Yes, sir.
Only point.
When everything is decluttered, the mind is decluttered as well.
Only point.
Yes.
Decluttered and consistency.
Yes.
These two things are there. You can achieve anything.
Yes.
And one suggestion, back up your data. Your laptop is in trouble.
Yes, sir. The one benefit of not writing on copies is the backup thing. The softwares back up the things for you. You're always safe with that.
Good, very good.
Thank you so much,
Excellent
sir.
presentation.
Thank you so much, sir.
Yeah, yeah.
Thank you so much, sir.
Probably you can think of monetizing this concept, like, really good. Like if a PGs, I think you should be the go-to
First year
person.
residency,
Yes,
one can't
yes.
decide to go through these things.
And nowadays kids are so tech savvy. Like this is the way to go.
But my juniors asked me, na, ma'am, अपनी notes का एक soft copy भेज दो. That is also spoon feeding, na. They will not study then.
They won't
They
study.
every day ask me, ma'am, भेज दो notes. कल exam है, नहीं भेजूंगी. पढ़ो तो.
पढ़ो.
Thank you so much.
Good. So conclude कर दीजिए sir. हाँ. So with that we conclude this session, and I'm very happy. Like if you see the percentage of seats, like we are very happy to state that our hall was 60 to 70% full. So we had a very nice interaction. Like all of us, like we benefited a lot from this session. So thank you all.